All right, everyone, it is time to get started. My name is Rachel Taylor. I'm our Director of Nursing Services here at Archer, and I am super excited to hang out with you all over the next 30 minutes as we talk about all things pharm. So before we get started, I want to hear from you guys in the chat, in the Q&A, wherever is easier for you, of how do you feel when it comes to pharm content? Let me know if you were to rate yourself like a 0 to a 10, how do you feel like your confidence level is? Okay, I'm seeing like a 4, 5s, 2s, 6s. I'm gonna be honest with you all on something. I did not feel confident in pharmacology at all until I started practicing as a nurse. It was overwhelming as a student because it was like, well, what meds do I need to know? What about the med do I need to know? Because there's a million different things that you can know about medications and pharmacology. And what I found was it was best to focus high yield and really make sure that I understood the key things for the medications that I would most likely see on my exams and for the NCLEX. And that's how I want you guys to start thinking. I don't want you to feel like you have to know every little thing about medications. You don't have to know every little detail. You have to know when to question it, when it could cause harm to your client. Why do we use it and what do we expect it to do? And when you start thinking about it in this sense of it being a bigger picture, it becomes a lot easier. It becomes a lot easier. Can you guys hear me okay? I've got one person saying they can't hear me. Is everyone else hearing me okay? Okay. I'm going to send them a quick message to make sure they can get in, and we will keep on going. So I want to know, where are you all joining from? So I live in South Dakota. Why I love asking this question is I love to see how we have one common denominator that really unites us all, which is nursing and prepping for exams. So we have people from, let's see, Chicago, California, Tennessee, Florida, Georgia, New Jersey, Virginia, Houston, Seattle. I was in Seattle for NSNA last year. Loved it. I had a lot of fun. Boston, Minnesota. I grew up in Minnesota by Rochester, if you know where that is. Illinois, in the UK, which is super cool. Salt Lake City, Canada, Long Island. Lots of people in Chicago. Fun, chilly, really cool. Western Australia. It's on my list to go there one day. I'd love to go to Australia. Okay, amazing. Uganda is somebody else. And I think it's really cool because it just shows that we are all united by one thing. And that thing is prepping for our nursing exams. Who's graduated already and who is still in nursing school? If people still in nursing school, some maybe still graduated, new grad, how exciting. Graduated a year ago, just finished my program the end of January. Looks like some of you graduated a long time ago. You've been a nurse for 20 to 30 years. Amazing. Some taking the NCLEX this month. All right, well, let's jump right in. Our topic today is going to be maternity. We're going to go over maternity medications. And what I think is so fun about doing this is you're going to guess what I'm talking about. I'm going to give you like a little descriptor and you're going to guess what we're going over. So this medication is a first-line uterotonic agent used for both the prevention and management of postpartum hemorrhage. So there's a lot of details here. What I want you to get used to of what matters, what's actually important, because that's what you want to get to with pharmacology. So it's used for the management of postpartum hemorrhage related to uterine atony. It works by stimulating uterine smooth muscles, increasing the frequency and intensity of uterine contractions after delivery. This medication may be administered IV or IM. I always think figuring out how it's administered is good, because if I'm giving something I am, but it's supposed to be given IV. That's a big major issue, right? So we want to know that. And then continuous monitoring of uterine tone, lochia, and maternal vital signs is required during administration. So what medication do you all think I'm talking about? And you all are getting it right. You're so smart. I don't think I would have got this right when I was a student. I'm just going to throw it out there. Yeah, oxytocin. So let's talk a little bit about oxytocin. So oxytocin it's actually a hormone that we have. And what the body naturally does with oxytocin is when this is released, it causes us to kind of squeeze down, to contract specifically in that uterine wall. The benefit of doing so is it's going to get everything out of there. It's going to prevent that postpartum hemorrhage from happening. Now, with this hormone, we can give it to our patients, right? And so when we give this, most often it's going to be given IV as a piggyback using an infusion pump, because we want to make sure that we're really accurate in how much we're giving our client. And then the other thing that's really important is we're kind of hanging this with another infusion. So that way the Pitocin, it can easily be stopped without stopping other fluids or other electrolytes from being given if they need to be given. One thing we want to note, and I say this from experience of being a patient, when we give Pitocin, do you guys think it increases pain at all? Or do you think it's like just regular contractions that they would experience? What do you think? It kind of forces that body to squeeze down before it's ready, and it is significantly more painful, and we want to warn mom of that. And the reason why is that might change pain management birth plan if Pitocin needs to be given. We want to make sure that that's already been thought about. Now, one thing I want to tell you guys, if you're like, hey, talking about pharmacology is stressful, it's a little bit hard. We do have in February, sorry, I don't know why it says January there, but in February, we do have a crash course, our pharmacology crash course. It's 10 hours. It is $75, but you do get the recording. So if you ever are interested in that pharmacology crash course, you can scan that. You can even just look up Archer Review pharmacology crash course. So that would be the other thing that you could do. Now, some questions came through. There's pain with contractions. Yes, there's absolutely pain with contractions with oxytocin. It's just more painful with the medication than it would normally be without the medication. We pretty much always like Pitocin running with fluids. It's not always lactated ringers. It could just be normal saline. It kind of depends on the doctor. But typically we are going to run it with another fluid. So that way there's continuous kind of fluids going if they are needed. Okay. This medication is administered to a postpartum client who is Rh negative. Without me saying anything else, you should know what I'm talking about. I don't even need to give more descriptors. Now, someone popped in the Facebook chat, and I want to answer this for all of you live, because there's an important point that I want to talk about here. They said, hello guys, I took my NCLEX today. I went all the way to 150. I had 6 case studies and a lot of SATA and a lot of priority. I am so stressed and scared waiting for the results. Number one, huge shout out to you for doing it. It can be hard to take that exam, but you can pass at any number. Anywhere from 85 to 150 questions, you can be successful. And I've seen thousands of students personally pass at 150 questions. So when all of you go in, if you're taking your NCLEX, plan for 150 questions. Don't plan for the 85, plan for 150. And then make sure you take breaks at question 86, at question 115, because you're going to need those breaks. So that way you are able to be critically thinking and utilizing your clinical judgment on every question that you see. Now, you guys all got this one correct when you're saying Rhogam, okay? Let's go through if there's any other really important information here. We give this after they deliver an Rh positive neonate. When else would we give this? When else would we give it? It's not just after delivering. When else? Yeah, typically we're going to give this if they have miscarried, and the mom is Rh negative. If they've had an abortion, if they have an ectopic pregnancy, absolutely. At 28 weeks gestation, we give it. Why? Because fetal and maternal blood may mix a little bit. And if fetal and maternal blood mix, what happens? Mom can start to create these Rh antibodies. Now, someone said a trauma like a car accident. Absolutely. If the blood cells, if there's any chance fetal and maternal blood cells have mixed and mom is Rh negative, they need Rhogam. Now, here's my favorite way to remember Rhogam and when it needs to be given and when it doesn't. I personally like to remember with Rhogam that I have O positive blood. Do I ever need Rhogam? Would I ever need Rhogam with O positive blood? No, I would never need it. So what I think is the most helpful way is to know your own blood type and say, would I need it or not need it? Or you can remember mine if you want, but that's just one extra thing to remember. And knowing that I have O positive, I would never need Rhogam. It makes it very easy to remember that, okay, negative is when I would need that Rhogam. That's what's helped me for years and years since I was a student. Now, the other thing I want you to kind of understand is the Coombs test. So there's a direct and indirect. How I think is easiest to remember the difference between direct and indirect is direct is on the newborn, indirect is on the mother. So direct is on the actual newborn once they're here, and indirect would be on the mom. And so that's the easiest way I find of figuring out the difference, because I used to get that mixed up pretty frequent. All right, are there any questions so far? We're almost halfway through our session today, but are there any questions that anybody has? Okay, let's keep going. So this medication is a second-line uterotonic used in the management of postpartum hemorrhage when uterine atony does not respond to the first-line therapy. Okay, so we had a first line and now there is another medication. It works by producing sustained uterine contractions through direct smooth muscle stimulation. Okay. This medication is contraindicated in clients with hypertension, preeclampsia, or cardiovascular disease due to its potent vasoconstrictive effects. Prior to administration, the nurse must assess blood pressure and continue to close monitor for hypertensive crisis. So I've had to take this medication before, and let me tell you, I felt like my blood pressure went up. I don't know that it actually did, but I felt like it did. I felt like I was getting hypertensive after taking this medication. And so what it is it is methylgonavine. And so with this medication, typically we refer to it as Methergine. So when I was talking to my nurses about it, I was saying methylgonavine, and they're like, what are you talking about? And I was like, Methergine is what I'm talking about when I had taken it. Really what it's doing, it's like, okay, oxytocin didn't work. There is a high risk for postpartum hemorrhage. We are going to then go ahead and give Methergine as our second option. Now, someone said, isn't Rhogam given at 28 weeks? Carly, absolutely it is. Yes, we talked about that. Why? Because maternal and fetal blood have this natural point of mixing at that point. We want to make sure that those Rh antibodies, anti-antibodies are not being created. Very great question. Any other questions? Someone asked about dosing. Dosing is going to be very specific to what is happening, why we're giving it, weight of the patient, all of that's going to look different. I personally have never memorized for every drug, every single dose that I'm going to give. Really, the only dosage I ever have memorized is that we never give more than 4,000 of acetaminophen. Like that's probably the only dose I have memorized in my head. Oftentimes I'm referring to other, drug books. And when you've given them enough times, norms for different meds, but I wouldn't sit and memorize every dose per kilogram per every med. That's going to take way too much. Okay. Way too much. Okay. Here's our next one. This medication is administered to a pregnant client at risk for preterm delivery between 24 to 34 weeks. Okay, here's the key thing. It is going to be given for preterm risk of delivery. Its primary purpose is not to stop labor, but it accelerates fetal lung maturity. It is given as 2 IM injections 24 hours apart and may cause transient maternal hyperglycemia. The nurse should monitor clients with diabetes or gestational diabetes closely following administration. What do you have here? Amazing. Vanessa said, this is my second to the last live lecture with Archer. Thank you, Archer family, for all you helped. Passed my NCLEX last January 20th. It shut off at 143 or 145 questions. I feel sad. Someone like separation anxiety used Archer Review for more than 3 months. Sure pass. And you guys really helped me enhance my nursing knowledge and skills. Thank you again for helping us. God bless you all. Thank you, Vanessa, so much for that feedback. We really, really appreciate it. Really, really appreciate it. If you could put that in a public place, like on your social, and tag us, that would be amazing. It does help us a lot for people just to share their journey. But really, congratulations, Vanessa. Super excited to have you in the nursing profession. Okay, the medication that we are looking at is we are talking about betamethasone. And this is a really silly way to remember this. But one of the ways that I was taught to remember this by actually a student I had when I first became an educator is she came up to me and she said, bet me some lungs. And I said, what are you talking about? She's like, it's how I remember betamethasone, bet me some lungs, because we want that lung development to happen. And so really what it's doing is it's making it to where, if I go back here for just a second, with betamethasone, what it's really going to do is it's going to try to make it where those lungs are more mature and they're not going to collapse at birth, right? Because so that they're ready to take on kind of the world on their own because they haven't been fully developed yet. Okay. Yeah, you're right. It's kind of like a surfactant for the lung to mature. Absolutely. You got it. Great job. Okay, those were the maternity style ones that I had, but I have some others that I want to go through together. I want to do a couple mental health ones. Is everyone okay with that? Everyone okay with that? Okay, I'm seeing yeses. Now, someone asked me, hey, wait a second, what's a tocolytic? Does anyone remember what a tocolytic is before we get into a mental health med? What's a tocolytic? Anyone remember? It might help if my chat stayed up with you guys. Good. A tocolytic, it's going to actually kind of suppress those uterine contractions. So somebody asked that last medication, betamethasone, is that a tocolytic? What do you guys think? Would that be a tocolytic? Did it do anything for contractions? No, it didn't do anything for contractions. What did it do? It helped develop the lungs to help them be ready for when this baby is born. So they're ready to be outside of the womb, right? Because the lungs, they take the longest kind of to develop there. And so we want to help get them ready. Okay. Typically, magnesium sulfate is kind of the main tocolytic that I can think of that I've seen given. Terbutaline would be the other one. Yeah. Yep. You got it. Latifa, you got it. All right. We're going to move on to our mental health medications. So this medication is prescribed for a client with bipolar 1 disorder who presents for routine follow-up. The nurse notes that the client recently started an ACE inhibitor for hypertension. Reports nausea, coarse hand tremors, and new onset of confusion. Laboratory results reveal a serum level of 1.9, and the client reports decreased oral intake over the past several days due to a GI illness. Okay. There's some key things that we've already seen going on here. What are the key themes you all are noticing? Yeah, you guys are getting it. Absolutely. I see lots of the right answers coming in. Yep, you got it. I did not bring water into my office with me, and I should have. So if I cough 1,000 times, I'm sorry. All right, you guys got it. It's lithium. So with lithium, there's some key things I want you to understand. Normal water and sodium intake is so, so important. And the reason why is lithium is a salt. So if my body has an imbalance of fluid or salt of sodium, guess what it does? It's going to hang on to that lithium. It says, I need a salt. I'm going to replace it, and I'm going to hold on to the lithium. Well, the problem is we can end up with too much lithium. And if we end up with too much lithium, we end up with toxicity. One way to remember what's okay with tremors and what's not, fine tremors are fine. Coarse tremors are the indicator that they're actually toxic. And what it's doing is it's really promoting that GABA neurotransmitter. So it's kind of helping a little bit with how those neurotransmitters in the brain are communicating with one another. So here's kind of the differences of what we see with toxicity at the very end. Like if they're severely toxic, it can lead to death. And that's why it's a big deal. When they start to actually have vision changes to the point that, hey, they're having blurred visions, it's actually advanced toxicity, like we should have done something before now type of thing. Early toxicity is when we start to see those EEG changes and those coarse tremors. Okay, so I want to ask you guys, what questions do you have? Whether it's about NCLEX prep, nursing school, you're a new grad and you're starting on the floor, what questions do you have? Because I really want to remind you that Archer is here for you across the whole journey of the nurse. And so any questions you have related to any of those is something that I want us to talk about. Oh, let me go back one slide. I went one too far. We really try to support you at every single stage of the nurse. So any questions you have, if it's, hey, Rachel, my NCLEX is in 2 weeks. What are some tips you have? Or, hey, I'm in nursing school and I'm starting to feel a little burnt out. What do you have? I want you guys to ask those questions. So someone said, is lithium for manic bipolar only? Do you do renal labs as well with lithium? Yeah, I'm going to check the kidneys. If the kidneys stop working, the chance of them getting lithium toxic is high. We would use this as like a maintenance med. We want them to take their lithium all the time. What you can see happen with lithium is it kind of suppresses them a little bit. It kind of calms them down. And what our patients will actually do is when they stop the lithium, they get where they can accomplish more. They feel like they're doing more, and they start to feel like, wow, I'm accomplishing a lot. They go into what's called a hypomania. When they go into this hypomania, we see that they, in that hypomanic state, they're actually more efficient. They're staying up all the time, but you can only stay in that for so long before they go into a full manic episode. And that's the point that they stop going to work. They stop eating. They no longer are productive. And so that's why we see that so often with lithium, it can be hard to get patients to stay on their medication because it does actually kind of depress them a little bit. And let's be honest, no one wants to feel that. Like no one wants to feel like they're being slowed down, but it does keep them so that they're in that window that they should be. Okay, let's see. I saw a lot of questions come through and I want to try to get to as many of these as I can. So if you have more questions, I want to talk about them. But one of the first things I'm seeing as just kind of a general, like, Rachel, I'm scared for this test. Guys, number one, the NCLEX does not define you. It doesn't define your capabilities as a nurse. Yes, you have to take it in order to practice as a nurse, but you are not defined by your result on this. Do not let the fear of failure be what holds you back from this great opportunity of joining the nursing profession. You have to remind yourself that you are capable, you are worthy, and you can do hard things. What I recommend doing is getting 4 highs or very highs consecutively on readiness assessments, as well as following an Archer review study plan. So somebody said, hey, I don't know what to do with Archer. So I'm just going to go ahead and show you guys. Can you all see just my regular Google screen right now? You should be. If you go to Archer Review and you're like, I don't know how to use this program, where do I start? This is overwhelming. You're going to go ahead and just start by logging in. Thought I was logged into this before I started, so it must have just logged me out. But when you log in, if you actually go, once it loads for me, to the QBank, and you go to the circle with the mouse, click that. It's a whole getting started guide. It's me going through every aspect of our program and how to use it to be successful. Because I want you to not just have the tools, but to know how to use the tools correctly. So that's where I would recommend starting. All right. If you have your exam tomorrow, remember you can do this. You don't have to know every single question. Go in with confidence. Take a break at question 86 and 115. What tips do I have for the week of the NCLEX? Guys, this is going to be the easiest. If you have an Archer program, go down and go to study calendars and go to week of exam study guide. There's a whole study guide for you to follow the week of your exam. The other thing that we have is if you go into your video library, there's also a tips for the week of your NCLEX exam. So Rudy, that was kind of the perfect question. There's this testing tips for the week of your NCLEX. It's just me talking for 10 minutes, but it's my best practices for before you go take your NCLEX. And I've helped thousands and thousands of nursing students successfully pass their NCLEX exam. Someone said, is it possible to finish your QBank in 2 weeks? Is it possible? Yes. Is it best practice? No. I would not recommend prepping in shorter than 4 weeks. I personally, as an educator, I feel strongly about a 4-week minimum. We do have a 3-week plan, but 4 weeks is my favorite. 6 weeks is my ultimate favorite, but 4 weeks is the shortest. Okay. And the reason why is because I want you to make sure that you give yourself time to truly understand. I can go to the gym every day for 2 weeks, but you know what's more successful? If I go to the gym 5 days a week for the next 2 months. And so if you want to think through, how do I give myself the best chance of success? Someone said, hey, I did a 3-day trial. I went in and did a readiness assessment. Will I be able to see the scores? When you register and you take a readiness assessment after registering, yes, you get to see high, very high. Here's your percentage breakdown. Here's how I did, all of that. Until you take your test in a week, I want you to follow this testing tips for the week of your NCLEX. I also want you to review this week of exam study guide. Those are my best 2 things for week of. All right, let's see. February 23rd, if you haven't started prepping with Archer, start prepping. I highly recommend using a package that includes content and questions. So what you'll notice about the Archer Review platform is we're not just a QBank. We are going to have video content, study plans. We have Monday, Wednesday, Friday live lectures with our Sure Pass package. Those are the things that really make a huge difference, as well as our 3-day live review. My mindset is if you're going to prep right. Let's get it done the first time so you don't need a reattempt. Now, if you do need a reattempt, let's make sure your next attempt is your last attempt, is my mindset 100% of the time. If you are working 4/12s, we do have a plan. Our 9-week plan is actually for those that work 3/12s. I would kind of adapt that to be whatever you would need it to be. All right. If you guys have any questions, someone did ask, what's the aim percent of practice questions should we get? It's not actually about getting a certain percentage. I do see a lot more success when students are at 65% and above. But I really recommend trying to get above the peer average. I think that makes a big difference in your readiness assessments. All right. I know I did not get to every question, so I'm going to go ahead and give you all my email. If any of you need anything, reach out to me via email anytime. My email is rachel.taylor@archerpulse.com. So Rachel is RACHEL.Taylor, TAYLOR @archerpulse.com. If you have a question, I might not get to it today. I'm a little behind in email, but I do want to help you. I want to see each and every one of you be successful. Someone asked a great question, and I'm going to answer it real quick before I hop. I know we're out of time. If you haven't gotten a response from me, it's either one, because you emailed me over the weekend. I haven't done my Monday emails yet, or 2, sometimes people spell my name wrong. So just double check that you spelled it correctly. But someone said, what changes are we going to change C starting April 1? The biggest change is you're going to see unfolding case studies that don't just look at one client, but they look at 2, 3, or 4 clients. The content is really not all that different. It's making sure that we can deliver care to patients that might be different from us, that we're thinking about patients who may be transgender or identify differently from us, that we are inclusive in our care. That's kind of the big things that you want to look for. I will type my email in these chats. I will tell you, I will probably, if you email me right now, it'll be a response tomorrow. If you've already emailed me and you're waiting for a response, just don't send a new email. Just wait. I always answer them from oldest to newest. Someone asked, which package of Archer reflects the new version? Every package of Archer reflects the new version, and here's why. There was only 3 activity statements that changed, very minimal content. We already knew about these unfolding case studies following multiple clients. We already have done that. So you could buy any Archer program and it's prepping you for the exam of 2026. It's not a crazy new exam, very minimal change, nothing that you need to be overly stressed about. All right, guys, it was really fun hanging out with you today. If you need anything, as always, let me know. But I hope you guys have an awesome, awesome day. And I hope to see you at more of our events, especially all those lovely pharm events that we have, including our pharmacology crash course. Have an amazing Monday, and we'll see you next time. Thanks for being a part of the Archer Review family.